All right, good afternoon or good evening, good morning from wherever you're tuning in from. My name's Troy, and I'm the Chief Operating Officer of Nurses Specialized in Wound Ostomy and Continence Canada. And I'm so excited to have you on again for another one of our continuing education webinars. This is actually part 4 of our Advanced Wound Care Strategies and Lower Limb Care series that we've been doing throughout this fall, and that we'll be continuing to do throughout the fall and into next year. And this is a program led by some of Canada's top wound care thought leaders. We've got 2 amazing guest speakers with us today. But before I introduce them, I just want to say thank you again to the Canadian Home Care Association and Perfuse Medtec for their support today for this webinar and for all the others in our series. I can see that everybody in the chat's already doing it here, but if you haven't already, do type in the chat box where you're tuning in from so we can get an idea of where everyone is coming in from across Canada. Lots of Blue Jays vibes here. Go Jays, go. And yes, we have a Blue Jay on our screen here. 2 reasons for that. One, of course, is that today is Game 3 of the World Series. The Jays are playing the Los Angeles Dodgers, but also because a little trivia fact for you. The geko product, which is going to be mentioned in this, or has been mentioned in this series, and you'll be learning about a little bit more today, has a sister product called the Firefly. And this is used by over 1,000 teams reliably for muscle recovery. So you might have heard of this before, maybe you haven't, but the Jays use it, and many of your favorite teams probably do as well. So we thought we'd give a quick shout out to that one there. I'm going to stop sharing now, and I'll invite Andrew behind the scenes to start sharing their slides over there while I introduce our guest speakers for today. So I'm very excited to be having with us Dr. Robyn Evans, who's a medical director of the Wound Healing Clinic at Women's College Hospital and a family physician in Toronto. With over 15 years of experience managing complex wounds, she's a lecturer at the University of Toronto, serves on the board of Wounds Canada, and co-directs the Wound Champion program, helping build clinical leadership in wound care across Canada. And of course, we also have with us today Dr. Gary Sibbald, who's a professor of medicine and public health at the University of Toronto, founder and executive director of WoundPedia, and lead of Project Echo Ontario's Skin and Wound. He's an internationally recognized dermatologist and internist with more than 200 publications and is the co-editor-in-chief of the Journal in Advances in Wound Care. He also co-founded the International Interprofessional Wound Care Course, or IIWCC, which has trained clinicians across Canada and worldwide. Just a reminder that tonight's session is being recorded. All of the previous ones in the series have also been recorded, and you can watch those online at www.nswoc.ca. And we are going to be having a Q&A period at the end of this webinar. Given the amount of content we're covering tonight, we might run just slightly over the hours, so we ask for your patience, and hopefully you'll stick on with us. We're going to get through some great content, though. So without further ado, I'm going to pass over the mic and the slides to Dr. Evans and Dr. Sibbald.
Welcome, everybody. I'm going to give it a start. I hope to fire everybody up on leg edema just in time to watch the game. I also want to thank geko for supporting this talk, and we're thrilled to be here to present this talk on leg edema. Next slide. All right, these are our list of conflict of interest, which I'm just going to leave you to read. You can, if you have any questions, you can let us know. Thanks. Next slide. All right, get into the meat of the matter. We want to define edema and consider what causes or the pathophysiology of fluid collection with emphasis on the lower extremity, and then use the history and the physical exam to link edema with clinical findings. We would then want to apply these best practices to manage edema and prevent complications, and of course, most importantly, to educate patients about edema and improve quality of life. Next slide. So voting question number 1, can you please just list where you're from in terms of your background, whether you're a nurse educator. The list is up there, and just if you wouldn't mind taking a second. This really does help us in terms of designing future programs, how deeply we should be delving into these topics.
And go to the highest one that applies to you in the list, the highest number that applies to you. And if it's other, please specifically list in the chat.
Lots of people coming on. I think I saw someone from Adelaide, from the Philippines. Wow. Flying by here. Okay, how are we doing?
We've got about 70% participated. Are you okay to end the poll?
Sure.
There we go.
So what do we
And you
have?
should be able to see the results in front of you now.
Okay, so 38% RN, RPN, Nurse practitioner, nurse physician, 1%. All right, that's great. Thank you very much for doing that, everybody. The next slide. All right. So it's not enough to figure out, what we can put on top of a wound that's leaking or the extremity that's leaking. We have lots of dressings, lots of things we can do and multiply on top of one another, but we really need to think, what is the problem? We can't just plug the hole. We need to understand the cause of edema. It's like anything else in wounds, you got to treat the cause. Next slide. Okay, edema. So to define it, is swelling produced by expansion of fluid into the interstitial space. And if you look at that round diagram on the right, you can see an artery and a vein and a capillary and a lymph on the bottom. And in between is the gray area, which is the interstitium. And fluid's actually appearing in that interstitium. So as I tell patients, we need to get fluid out of the tissue and into the tubes and back to the heart. And that's the most important thing. If you think about it, though, edema occurs in almost any place. In the lung, we call it pulmonary edema. In the abdomen, it's referred to as ascites. The heart, it's pericarditis. If it's total body, it's called ansarca. Lower leg, it's either lymphedema or peripheral edema, or combinations of all of these things. Next slide. Now, I don't want to scare anybody off the pathophysiology, but if you look on the left, that's the heart that pumps blood through the arteries into the arterioles and into the capillary bed. Perfuses tissue, does oxygen exchange and nutrient exchange, and then it takes things back to the heart through the venules and veins. Intermingled in all of this is the lymphatic system, which intimately aligns with the venous system. What's happening in the blood flow that involves edema is that the arteries supply the high pressure system into the capillary bed. So that's called the hydrostatic pressure. High pressure, it's red, it's the arteries. And when it's high pressure, fluid moves to areas of low pressure. So fluid leaks into the interstitial space. As it goes along that capillary and it heads towards the venous end, it's low on pressure now, but the oncotic pressure in the tube is actually high now. And the oncotic pressure is a result of protein. And protein you're going to hear a couple of times in this talk. That draws fluid back into that venule end, and hopefully all of it goes back up to the heart. That's Starling's law. It seems quite simple, but we know it has to do with pressure and proteins. Next slide, please. In the tissues, it might be a little bit different than that. What I just described is probably really true for the kidney, but in the capillary bed, we have this lymphatic system, and mathematical models and all sorts of investigation have gone to look at what is actually going on in the interstitial space. And it's not as pure and simple as Starling's law. Because the lining of the tubes has a glycocalyx, proteins actually do cross the membrane and the fluid does shift. So we call it a modified Starling's law. And that other fluid that arrives there is probably taken up by the lymphatic system, which I'm sure you're going to hear a lot more about. And some readings will suggest up to 70% of fluid can go back in the lymphatic system. So it's an intermingled, tightly controlled environment. Next slide. So Dr. Sibbald will go on with the clinical stuff, and I'll be back soon. Thank you.
Okay, so the first question to answer after identifying yourself is the 2+ pitting edema in this patient is associated with, and actually if you look at that pit, it's probably almost a 3 or a 4+. Is it due to venous disease, venous lymphedema, lymphedema alone, lipedema? All of the above are answers 1 and 2. So enter and sign in, please.
And we'll give it just a couple more seconds. Lots of participation so far. We'll see if we can get to 50% there. Alrighty, a range of answers here. We're about 50%. So I'm going to end it here. Last chance, everybody, and I'll share the results. And I have to apologize. On my screen right now, because you have so many people on, I have the percentages off, but I'll give you the number and see if I can estimate here. The highest response is answers 1 and 2, so both venous disease and venolymphedema, followed by venous disease, then all of the above, then lymphedema, then venolymphedema, and at last, with only 3 responses, is lipedema.
Okay, that's a good start. And you are in fact right that the venous and venolymphedema, but let's go on and look at this in a little more detail. Next slide. Here's venous stasis with what's called lipodermatosclerosis. And this is when in venous disease you get a woody hardness associated with the venous disease. And the woody fibrosis progressing to venolymphedema. Venous is the primary disease, lymphedema is secondary. And so what you've got here is woody fibrosis going all the way down to and including the foot and the toes. So the dorsum of the foot is no longer soft and pliable, but it is hard and woody like a tree trunk. Next slide. And lymphedema is high protein edema. It is non-pitting. Remember that. The question was pitting. And that's why it would be venolymphedema. There is a positive stemmer sign. Stemmer sign is pinching the dorsum of the toe. And if you can't pick the skin up between the thumb and the first finger, it is likely lymphedema, or it is known as a positive stemmer sign. And that toe's intact and the skin is not lifted up. And inflammation will lead to fibrosis and subsequent sclerosis. Next slide. And there are 3 stages in lymphedema. The first stage is reversible. Bed rest, elevation, no tissue changes. But, we really replace bed rest with compression. Stage 2 is irreversible, hard to pit, fibrosis is evident. And stage 3 is called elephantiasis. It's where you get gross skin changes. The epidermis can have a warty-like appearance, and you can get dermal nodules, and you have severe fibrosis. Next slide. Here is lymphedema with retention hyperkeratosis, and this is where the scale on the surface of the skin from the stratum corneum becomes much thickened. And you can see that the dermal tissue, if you look towards the top of the left-hand side, is thickened as well. Next slide. Lipedema is excess fat, and it's characterized by an increased layer of subcutaneous fat without alteration of the venous or lymphatic vessels. Often obese individuals with outflow obstruction, but this can also be genetic. But look at that ankle fat pad sign where the fat kind of rolls around at the ankle. And the dorsum of the foot is involved, but it's soft, not hard. And if you put on high compression on these individuals, it's extremely painful because you're actually squeezing the arterioles in the lobule of the fat. Next slide. And if you want to take a picture of this, please go ahead. But we are looking at the difference between arterial disease, where you have a cold extremity, pale dependent rubor, that means when it's down, it's red. When you elevate, it blanches. Thin and shiny skin, negative stemmer sign. The loss of hair and the thick nails are not a very good sign, and they don't really hold up in studies. Capillary refill does, so that when you press on the capillary to whiten the skin, it doesn't flush in less than 3 seconds, which it would with venous disease, where you have an ambient temperature, you may have hyperpigmentation, you can get pitting edema early, but as lipodermatosclerosis, as you get that woody hardness and a negative stemmer sign, this is progressive venous disease. the hair and nails are normal, and the circulation time on the dorsum of the foot is less than 3 seconds. Lymphedema, again an ambient temperature, flesh color or hyperpigmented, woody fibrosis, positive stemmer sign, the wart-like verrucous epidermis, the dermal fibrosis. You often have hair loss, thickened nails, and capillary refill because you can't compress, it's indeterminate. Lipedema is flesh-colored, red, hyperpigmented with secondary lymphedema, can occur. It's usually localized and often initially in the gaiter or the lower third of the calf. The skin is soft, negative stemmer sign, but late secondary lymphedema will make it positive. There is that ankle fat pad sign we pointed out. Hair and nails are normal, and the circulation time less than 3 seconds. Next one. Here's the progression of venous disease, and it starts with dilated saphenous vein. You see that on the upper left side. Superficial varicosities and varicose veins, lower leg edema, and then you get pigmentary changes of the distal leg. So that's leakiness of red blood cells from the capillaries, leaves behind hemosiderin and melanin. It then get the woody fibrosis as fibrin is released, often on the calf area before the foot. Then you get the woody fibrosis, and leave it to dermatologists to come up with the word lipodermatosclerosis. Next slide. The changes around the malleolus of this patient are associated with, is this a condition called livedoid vasculopathy, vasculitis, pigmentary purpura, superficial phlebitis? Is it a function of venous disease, or is it all of the above? Enter and sign in, please.
Alrighty, and this time I will be able to see the percentages for you, so we'll leave it up for a couple more seconds. Perfect, and for those who can't access the poll or there's any issues, thank you for using the chat there. That will work just the same. Thank you. Alrighty, and nearly there. Okay, and so we've got 41% say venous disease, 22% say all of the above, 13% vasculitis, 11% pigmentary purpura, and then 9% livedoid vasculopathy, and then 4% superficial phlebitis. You're going to have to excuse my pronunciation of that last one.
Okay, this is actually part of venous disease, and you'll see this shortly on the next slide. This is called the CEAP, or CHEP classification, and we're just going to look at the clinical manifestations. And as you see venous disease, you'll start with no visible or palpable signs. You first see telangiectasia. These are thread-like blood vessels. Then varicose veins. You can get recurrent varicose veins even after they're treated. Then we get into the stage of edema. The changes in the skin and subcutaneous tissue secondary to chronic venous disease in the C4 clinical 4 group. First of all, pigmentation or eczema, sometimes called stasis eczema. There's that big word again. Lipodermatosclerosis, it's woody hardness of the lower leg. Atrophy blanche is actually when small venules and capillaries get clogged and you get a clot. And this results in a little ischemic area, and you get a white area of skin because you lose the hair follicles, the blood vessels, and the sweat glands. Corona phlebatica, you wonder that's some foreign name, but that's actually the picture you just saw. A healed venous ulcer is a C5, an active venous ulcer is a C6, and an active venous ulcer with recurrence is a C6R. Next slide. So here's the start. Those are those small purple, blue to red, common on the legs, half of the US population, and they occasionally bleed. They're not harmful, by the way. Can be large and bulging if symptoms are heavy, tired, sore, or itchy. You might consider treatment. And varicose veins can be symptomatic. You can get a superficial and a deep phlebitis. Next slide. Venous insufficiency with swelling. It often starts around the ankle. Look for swelling in the sock line. Push the socks down when you're examining somebody just to see if it's there. It's often worse at the end of the day or with travel. You should start wearing support stockings on airplane rides and not cross your legs. And then once you get more swelling, you should be wearing it every day. Slight to dark brown pigment. It's due to leakage of red blood cells, and it's a combination of hemosiderin and the melanin, and this may be permanent. You can use moisturizers, topical steroids. We advise that you use those at night and your support stockings during the day. If you put the creams and ointments on under support stockings, you'll wear them out sooner. Brown, dry, fragile skin often comes, the stasis dermatitis, before the ulcers. Next one. There's your corona phlebatica, or the starburst veins. They radiate down from the malleolus, and often this is confused with other disease states that I listed. And it's important for you to recognize this, that this is a variant or an extreme variant of a normal venous pattern. Next slide. Recently healed ulcers, only 80% of the tensile strength skin's never been wounded. This is why often in people with leg ulcers, when they heal, we ask them to bandage for 2 weeks or even longer if they're recurrent, because you get extensive dark changes, white scar post-ablation of the greater saphenous vein with healing of a long-standing ulcer. The lipodermatosclerosis, you can see where some of that's harder and it's a firm like picture. If Stemmerstein's positive, then it's venous lymphedema. And venous insufficiency with active ulcers, 80-20 rule, bandages for healing, stockings for maintenance. After 4 weeks of silver dressings, they're probably less effective. And there was a meta-analysis of studies that really showed you don't need silver forever. And consider you haven't treated the cause, or that you've not optimized other components, or you have a non-healable or maintenance wound. Look at Wound Bed Prep 2021 or 2024, freely downloadable. Consider medical therapy, pentoxifylline, interesting substance that it's a xanthine, it's like caffeine. It increases red blood cell contractility. It's fibrinolytic, it helps break down the fibrin, and it's anti-inflammatory. But there's a geko device you'll hear about later, and a skin graft, etc. Next. Pitting edema, a venous disease, commonly extends above the knee, may be bilateral, most prominent over the pretibial region, usually persist overnight. All of the above are answers 2 and 3. This is a bit of slanted question, but I'll tell you why in a minute.
Sorry about that, everyone. I accidentally just paused the poll there, so if I'll get you to just put your answer in one more time. There we go, they're coming in. Alrighty, and I will end it now. You should be able to see the results there, but we are looking at 68% say answers 2 and 3. After that, our next highest is all of the above at 13%. 9% say may be bilateral, and 8% say most prominent over the pretibial region, with 2% and 1%
Okay.
respectively for the final two.
All right. Now I put this in because it usually is most prominent just above the medial malleolus. And when you're checking for early pitting edema, that's where you should check rather than the pretibial area, which may be tighter and may not show you the same degree of edema. When it extends above the knee, you really should start to think about, is there a systemic cause, particularly if it is bilateral? But certainly pitting edema of venous disease may be bilateral. That's the only correct answer. It is most prominent over the area above the malleolus, not the pretibial. And that's a common misconception. It usually persists overnight. It usually clears. So all of the above and 2 to 3 are not the most correct answer. Yes, you can check the pretibial area, but the area just above the malleolus may pick up edema a little bit earlier. Next slide.
Okay, I'm back. So thank you, Dr. Sibbald. Lots of clinical pearls in there, and I think this may help with some of those difficult questions that Dr. Sibbald posed. So fluid collection can be localized, it can be systemic, and of course, in most of our patients, it's complicated, so it can be a combination of both. Next slide. So if we look at the systemic causes, just about any organ system can contribute or cause edema in a body part. So the three most common would be nephrotic syndrome from kidneys. So that is a loss of protein that goes in the urine. You don't have very much protein. And remember I said you need protein to pull fluid back out of the tissues. Congestive heart failure, another volume overload system where the heart is not able to pull fluid back from the heart and there's a fluid overload. Cirrhosis of the liver. In the liver, albumin and proteins are made, and if you have cirrhosis, this is no longer efficiently done and it's quite low, so again causing low protein. Protein losing enteropathies, you can think of things like ulcerative colitis, will cause that. There are many causes I've looked at. You look at any organ system. I had a patient present a couple weeks ago with complete body swelling as a result of an adrenal tumor that showed up and again caused full body and Sakara. But think of these causes, and there can be multiple comorbidities. Next slide. Okay, but if we concentrate on the lower extremity, which I know most of you are looking at, it's usually a cause of venous, lymphatic, or arterial. So we can divide these things into three simple risk factors or contributing causes. One is valvular disease, so prolonged pressure in the veins, long pressure in the venous system, those veins dilate, the valves do not close as well, and over time you get this trickle effect of fluid not reaching back up to the heart and it remains in the tissues. And you can think of many causes. Employment, standing, all of us sitting all day, standing, a high BMI, multiple pregnancies, pelvic masses, the list goes on and on. Obstruction, major thing here is a deep vein thrombosis. If you elicit this history from your patient, remember it's a big contributing factor to venous disease. Next slide. The third cause is failure of the calf muscle pump. And this is a biggie. We know that the contraction of the muscles of the calf move fluid back up towards the heart. And if you can't do that, you're going to get a lot of problem with fluid in the tissues again. And you can think of many causes here. Again, you can have hip problems, knee problems, ankle rigidity, failure to be able to dorsiflex and plantar flex the foot will cause problems in returning fluid. Dr. Sibbald mentioned lymphedema. I'm just going to show it up here again. Most common cause in developed countries is post-surgical. Our patients, not so much maybe. We tend to see more as a result of other causes, but as a result of breast cancer or melanoma, anybody with radiation, post-surgical, or any trauma to the area can damage the lymphatic system. But we often get, as already been pointed out, venous and lymphatic issues existing together. Next slide. So the history and physical, this is where the big money is. Always do a good history and physical. Consider the comorbid issues, looking at the heart, kidney, and liver. And most of the time, you can get a real good flavor of what's going on by the medications your patients are taking. Look at those specific risk factors for lower extremity, venous, arterial, and lymphatic. And in terms of symptoms, pay particular attention if you're looking at the venous system, heaviness of the legs, itchiness of the skin, aching at the end of the day, or even restless leg syndrome can be a sign of venous disease. Arterial, you're worried about symptoms of claudication. And claudication is when a patient walks a distance and can feel pain anywhere in the leg from the buttock down, and it's reproducible. So you walk the same distance again, pain recurs. Think about this. You need to ask, because a lot of patients will just tell you they can't walk because they have arthritis in their hip. Night or rest pain, very concerning. That's called critical limb-threatening ischemia. Patients may tell you that as soon as they lie down at night, the pain starts. And this is a result of loss of the arterial drive down to the lower extremity. You've lost gravity. You put the leg up now, and it becomes critical in terms of there's no perfusion to the tissues. Patients will say they have to get up, dangle their leg over the side of the bed. Also, alert yourself to the systemic symptoms. In cardiovascular disease, maybe shortness of breath, chest pain, but looking at the history and an in-depth look might expose some of these more systemic causes. Always think about, the cause. You don't want to miss that one outlier, which is shown in the picture. We think things are venous, but they may not be. So an ulcer is an ulcer, but know the cause and treat that cause. I find the most important things about looking at this in addition is looking at onset. Is it acute or chronic? And is the distribution unilateral or bilateral? Next slide. So the physical exam, Dr. Sibbald went into this. Always look at your joint mobility. Look at the patient walking in and out of your exam room to see if they really can activate the calf muscle pump. Looking at all of these changes that we've described already, and that picture on the right sort of encompasses everything that you've already seen, the pigmentation, woody fibrosis, eczema, and finally this inverted champagne bottle deformity, which is a leg that's at high risk for ulcer formation. Lymphedema, Stemmer signs, and the most reliable clinical sign for arterial disease is, of course, the pulses. Please check the posterior tibial and the dorsalis patients, dorsalis pedis, and make sure you can feel those. Remember that the posterior tibial should be always felt in every patient unless the edema is excessive, but the dorsalis pedis can be absent in about 8%. Great, you can grade the edema. There's really no evidence for this, but this might help your clinical notes. Measuring the leg might be another way to look at it. Next slide. So let's do some cases, keep you awake. Mr. C presents with acute onset of swelling in his right lower leg. He's recently been diagnosed with metastatic colon cancer. What is the most likely cause of swelling of the right lower extremity in this case? So, is it low albumin related to GI loss, deep vein thrombosis, a pelvic mass on the right, all of the above, or 2 and 3? If you could just enter what you think here. How are we doing, Troy?
Alrighty, we'll stop it here and I'll share the results. We're looking like 24% say low albumin related in the GI losses. 22% is pelvic mass on the right. 22% as well as both options 2 and 3, which brings us to option 2, deep vein thrombosis is 15%. 17% say all of the above.
Okay, it's equal
Quite
across.
balanced, yeah.
Yes. So what is the most likely cause? Well, low albumin related to GI loss. So you were all listening at the beginning and you saw metastatic colon cancer. Metastatic colon cancer would probably not cause GI losses, and it would tend to be bilateral. This is only one leg. So metastatic colon cancer affects one part of the colon. It would have to affect a large part of the colon, like an ulcerative colitis or Crohn's disease. So it's not one. Could it be deep vein thrombosis? Well, I would pick that one because we know that with metastatic, any kind of cancer, deep vein thrombosis is more likely, high risk situation, and it's acute onset. So number 2, I think, is correct. Pelvic mass, possibly in this case, we know he has metastatic colon cancer, which could put pressure on the venous system, pushing down, and could well cause a problem. So the correct option is 2 and 3. It is a little tricky, but I want you to think about the patients and think about what the causes are. Next slide, please. All right. Next question. Mrs. R has long-standing swelling. Sorry, I have to move this out of the way. In her lower leg, she presents today with painless, fluid-filled blisters and increased swelling in both legs. She reports more shortness of breath walking to your clinic. What is the most likely cause of the edema? 1, worsening venous disease. 2, deep vein thrombosis. 3, cardiac or congestive heart failure, or options 1 and 3.
All right, and the answers came in much quicker this time. We have 75%, oops, I'll share it here, 75% saying both options 1 and 3, with 20% people saying cardiac or congestive heart failure, and then 3% respectively for both of options 1 and options 2.
Okay, so that's good. So this could be worsening venous disease. Obviously, there's lots of venous changes in that leg. So I think, yeah, you got that. Deep vein thrombosis, well, I think that's very unlikely. It's both legs. It seems rather chronic. So I don't think I'd be too worried about DVT, but good to think about it. And congestive heart failure, yes. Well, she's got shortness of breath walking to your clinic. Sounds like she's subtly in a little bit more congestive heart failure, building up some fluid, and commonly seem to get these little blisters forming in the lower leg. So the correct answer is 1 and 3. Next. All right. Mr. W presents with new onset edema, erythema in the lower leg. He has long-standing swelling, but the redness has not dispersed and the swelling is increased. He is on an antibiotic, but it's not helping, and they have actually ruled out a DVT. So what you see in that diagram, is that related to cellulitis, but he has an antibiotic-resistant organism? Is it chronic lipodermatosclerosis, a contact dermatitis, or options 2 and 3?
Give it a couple more seconds. Alrighty, about 50% participated now, so a little bit more balanced, but we've got at 43% cellulitis with an antibiotic-resistant organism. The next is at 31% chronic lipodermatosclerosis, and 24% say both options 2 and 3, with only 2% saying contact dermatitis.
Okay, so the correct answer here is this is chronic lipodermatosclerosis. You could think maybe it was a bit of a dermatitis there, but I don't really think it's so well demarcated. Cellulitis with an antibiotic-resistant organism is very unlikely in most people, and DVT has been ruled out. So this doesn't really look like a cellulitis with a resistant organism. The pain is not getting any better, but it's not painful. So I would say it's a chronic lipodermatosclerosis. And this is important to look at because a lot of our patients present with this. It's not hot or, the person's not sick. Often they're put on antibiotics. But the reality is this person wasn't wearing the compression stockings, got a little bit more edema, and we get this chronic sort of lipodermatosclerosis that can take on this appearance. Next slide.
It's often, Robyn, bilateral, and
Yeah,
I'll get consults in the hospital, bilateral cellulitis, IV antibiotics for 10 days, patient not better, please see. And, they're often in severe pain if it becomes acute. And when it becomes acute, they can't tolerate compression, so that you do need to use an anti-inflammatory and not an antibiotic.
Yeah, this is pretty common presentation. Just remember bilateral cellulitis would be extremely uncommon. Next slide. Case 4. Okay, Mr. S presents with bilateral lower leg swelling. This is an ongoing issue. He has cirrhosis and chronic renal failure. What is the cause of the lower leg edema? Is it venous disease, low protein related to cirrhosis, abdominal ascites causing pressure? Option 1 and 2, option 1, 2, and 3.
And just a couple more seconds. Alrighty, and I'll let that go now. So we're looking at, in first, we see options 1, 2, and 3 with 40% of the responses. 34% of the responses say both options 1 and 2. 16% say option 2, and then only 5% and 2% for venous disease and due to abdominal, I'm forgetting this word now, but anyways, 5 and 2% respectively for options 1 and 3.
Great. So it sounds like most people got the correct answer. There is venous disease. It's obvious there. You can see a lot of the changes. Low protein related to cirrhosis is very likely. We know he has cirrhosis. There's edema. So I would definitely pick that one. If you've got abdominal ascites, that's equivalent to a high BMI. Anything that puts pressure in that abdomen and pushes on the venous system can cause problems with venous return. So it's all 3 here. This interesting demarcated red line on his lower extremity. I don't know if anyone's seen that, but this gentleman had no idea what it was caused from, but in fact, the fluid had accumulated above his sock, and that caused the line there. And his red feet were also just from fluid. So fluid's a problem, causes a lot of problems for patients. And next slide, please. So just to summarize this, and hopefully this is helping in diagnosing edema and not creating havoc for you, but if it's acute and unilateral, think DVT. You can also think of other things like cellulitis, but I think the patient would have fever and pain and speak more to infection. Baker's cyst, sprain, and pelvic masses always should be in the back of your mind. If it's acute and both legs, think medication. Are they on a new medication? Amiodarone is a big one. Prednisone, nonsteroidal anti-inflammatory drugs. If the patient has acute heart failure, hopefully they're not in your clinic at that point and more in the emergency department, or nephrotic syndrome, again, low protein state, it would be bilateral. If it's chronic and unilateral, think of the chronic things that happen. So venous disease and lymph disease, lymphatic edema, pelvic neoplasm can put pressure both sides if it's slowly growing and long-term. And if it's both legs, again, the common things, venous disease, heart failure, and lymphedema. Cirrhosis, again, could be chronic because this cirrhosis may develop at a chronic slow rate. Next slide. All right, well, we all know now what causes edema, or hopefully we can, but we want to know what are the complications of this edema? Why is it so important to treat? Well, the skin changes of stasis dermatitis, itchy skin, scratching, introduction of bacteria, uncomfortable for the patient. Pain's a big factor for edema. It's uncomfortable. Quality of life issues. The shoes don't fit. Fluid is leaking. There might be odor. This woody fibrosis causes skin changes that may lead to ulcerations. And of course, delayed wound healing. We know edema delays wound healing. The blood vessels are further from where they should be, and the wound just doesn't heal as well. Infection can be from yeast or tinea due to fungus or just cellulitis. And a big problem is between the 4th and 5th toe. That's a good portal of entry and a very common cause of cellulitis. And mobility issues. We don't think about this, but a lot of people, as they get older with that leg edema, their mobility is not as good and falls are increased. Next slide. Next slide. Oh, there we go. So here's an example of some of these issues, a bad stasis dermatitis on the left, which you've seen, this nasty looking foot with, that wasn't actually a fungus, it was actually yeast which was growing there, sudden onset of lots of edema in the lower extremity, treated that actually with topical Canestin liquid and just painted it all over between the toes, responded really well. Or look at the next diagram, and this edema fluid is actually causing problems in that it neutralizes fatty acids that are actually important to bactericidal properties of the skin. So you can delay wound healing and increase the risk of infection. And of course, you don't have great perfusion, and blood flow is the currency of healing. Next slide. So management, this is where we all come in. Compression, evidence is considerable. Stay tuned for the Sibbald Evans show on November 24th when we'll talk about compression. Leg elevation above the heart, activating the calf muscle pump through exercises and appropriate footwear. Skin care is important. Moisturize, dry between the toes. I stole this little example of humectant and emollients from my colleague Sheena Fortuna, which many you may know. Humectants are sort of like watering the plant, where their emollients are like mulching. I found this really helpful to remember. So things like glycerins and lactic acids are like watering the plant, whereas the emollients like petrolatum are holding things together, the fluids there. And manage systemic disease, and don't forget to involve other specialties. When your spider sense says this is not just my problem, it's somebody else's as well. Next slide.
Just before we go on, humectant stratum corneum needs a 10% moisture content to stay intact. Humectants then on the stratum corneum also include urea in addition to lactic acid and glycerin, and they actually bind water. So you should apply them right after bathing while damp, and not if you've got open skin, or they will sting and burn. You need to fill in openings, and sometimes if you've got a big crack in the skin, using a film-forming liquid acrylate or petrolatum. Emollients, as Robyn pointed out, sit above the skin, and they prevent insensible water losses. So they're two different mechanisms, and don't use them both at the same time, or petrolatum or ointment vehicles will block the hydration sites on the humectants like glycerin, lactic acid, or urea, even ceramides. Robyn, back to you.
Okay, next slide, please. Thanks, Dr. Sibbald. So furosemide, everyone asks, and your patients will ask the same thing. Just give me a pill for this and the edema will go away. Well, if it's systemic, yes, but if it's a localized edema due to venous or lymphatic disease, you can volume deplete your patients and affect the kidney function. So just remember, if you took a glass of water and you filled it up, sort of representing fluid in the lower extremity, and you pour half of that fluid out, it's still in the lower extremity. So you're taking water from everywhere, which can be not a great idea. Obviously, for congestive heart failure, it works, but it's not ideal. Although when edema is significant, some people will use it for a short period of time, but just be cautious with this. It's not for everybody. Next slide. So there's other options. So you can see on the left, this is a patient of mine who brought his IPC, or intermittent pneumatic compression device, in to show the residents so they can see what it actually looks like. That is an option. It's an expensive option. The fitting is a little bit finicky. It's not that comfortable. He reported a lot of sweating of his skin, and of course limits mobility. It's tough to use. And then there's other options on the right, the muscle pump activator, which has been used a lot with edema and getting more and more evidence. So let's look more closely at this muscle pump activator. Next slide. So just quickly here, which is incorrect? This one's easy. Decreasing venous pooling and increasing blood flow. The geko elicits muscle contractions of the foot and calf. Does it increase fluid into the tissues? Has been studied in the prevention of deep vein thrombosis, or a similar version appeared on Shark Tank. What do you think? I think everyone's going to get this one.
We'll see. I'll leave it open for just a couple more seconds.
Sure.
Alrighty. So our final answers are tie for 3. elicits muscle contraction of the calf and foot, as well as increasing fluid into the tissues. And a similar version appeared on Shark Tank, all with 27% of responses. After that, 14% say decreasing venous pooling and increasing blood flow. And then 7% with question number 4 or answer 4.
All right. The statement of geko that's incorrect is it does improve blood flow, and Dr. Sibbald's going to show some slides. It elicits a muscle contractions. That's how it works. So it's a muscle pump activator. It does not increase fluid into the tissues. It actually does the exact opposite. It has been and has ongoing studies in the prevention of deep vein thrombosis. It seems to have some sort of fibrolytic effect. And a similar version did appear on Shark Tank, and it was introduced by Troy at the beginning, and it's used for muscle recovery, and hopefully all of our Blue Jays are using that going forward in this series. Next slide. All right, so the geko is a size of a wrist watch. It's very light, battery operated. I would recommend if you're going to put on patients to view the video. They show you 2 landmarking ways of finding how to put this on. It's very simple. It elicits a contraction once every second, and it can be worn up to 24 hours, but most commonly 12. Next slide. So, Dr. Sibbald, over to you.
Happens is if you look at the microcirculatory blood flow at the baseline with the geko, you'll see on the left-hand side, the flux increased 225% to the wound bed and 67% to the peri-wound skin. And you see this going up the whole lower third of the calf, so that we've really got a much greater flux here. Next slide. And it activates the lower leg muscle pump, so you would like to get a twitch response. And the venous valves support through muscle movement, baseline venous sludge index, and with the geko device activated, the baseline venous sludge is reduced to 7.65 from 53.5. So a big difference. Next slide. This is a study of over 200 patients performed in London, Ontario, looking at the geko device reducing duration of hospitalization, improving early graft outcome post-kidney transplant or kidney and pancreas transplant, and a randomized controlled trial by Dr. Siener. And what it showed was it was compared to intermittent pneumatic compression. And the geko device without the compression, the leg edema went down to 2.5 centimeters versus 3.6. And the weight gain was certainly less. We had urine output total, and you can see it was greater. High femoral vein velocity, again, was greater. And when you look at complex wound infections, because the edema went away faster, 20% with the pneumatic compression and 12% with the geko. Incisional wound healing, 104 patients, 29% were intermittent pneumatic compression, whereas 13% only had a problem. Length of stay, 8.15 days versus 9.36. Mobility, more steps, and hospital observation. So there's a cost savings of over $2,000 per patient with the geko compared to patients that had intermittent pneumatic compression. So I think this does show a big benefit in these patients, and I think this can be used along with compression and other modalities to improve healing. And you'll see some venous data when we come to the compression talk in a few weeks. Next slide.
Well, those are impressive results. Yeah. I like that part where you reduce the infection when you don't have edema.
Yeah, and I think edema is a great bacterial stimulator, and I think we look at delayed wound healing, We look at intolerance to adequate compression, slow to heal venous ulcers, suboptimal arterial supply, and patient-specific issues like leg shapes, size, tolerance to compression. So all of these might actually be indications for the gecko. Next slide. Here's a patient is an 83-year-old male, a 12-year history of venous ulcers, normal BMI, poor mobility, used a motorized scooter, stiff ankle, no use of the calf muscle pump, significant pain, good arterial supply, lipodermatosclerosis, so the woody fibrosis, edema, increased pigmentation, ulceration, bilateral, medial, and lateral ankles. And I think, Robyn, do you want to comment?
Yeah, I say that, we can use things like the gecko or muscle pump activators in many different patients, but it's important to target where you think it's going to work the best. I mean, obviously compression and all this stuff works, but there's a lot of cases, and I'm seeing more and more where I wish I had that extra thing to move that fluid out and actually elicit more blood supply to the area around the wound. You can see that wound has got a very scarred, very chronic looking appearance. I don't know what the blood flow is around that ulcer, but I would bet it's poor. And I think using something like the gecko, we know looking at speckles study, we do get increased local blood flow. We know venous disease actually causes a venous ischemia. So I think if we had access to that a little more often, this is kind of the case I would use it. Next slide.
Okay.
Sybil's going to go on to another one.
This is my case, and Mr. G is a 70 to 80-year-old male. Home care nursing for 3 to 4 months, not healing. Advised to have a below-the-knee amputation, arrived in a wheelchair. First seen in September 2023 following bilateral femoral artery stent with necrotic wounds to the right foot on the dorsum. So the toes 1 through 4 had black necrotic tops, and this is partly reperfusion injury. Pain was off the map. It was 15 out of 10. I was unable to touch the foot anywhere. He was sleeping, sitting on a couch with the leg down due to severe pain, not able to go upstairs, can't drive. Controlled pain, neuropathic and neuroceptive measures went from 15 over 10 to 2 to 3 over 10. First visit, we had an interprofessional clinic. We had doctor, nurse, and foot specialist. We changed saline to hypochlorous acid. We treated the gecko device, and this went on for 8 months, walking and returning to normal activities. And he has a 75-year smoking history and stopped a few months before we first saw him. But let's listen to him tell his story.
Yeah. So, Greg, if you're looking at this from the beginning to now, what's your functioning like now? You're walking. Did you bring your cane today?
No.
No. How about your pain level? What's that?
My pain level is if 1 is none and 10 is plenty, I'm sitting at about a 2 max.
Okay.
Very, very rarely is it occurring. My functionality in terms of walking, I'm walking virtually normally now. The only thing, the drawbacks are getting back some muscles, which I don't have.
You got it.
I also have some lung capacity that I'm working on, but that's a completely different issue. But overall, it's like night and day compared to where it was 12 months ago.
I did notice today that your right foot was a little cooler than your left, and you've had 1 episode since our last visit, but it lasted only 5 seconds. But it's making me a little reluctant to get rid of the nitro patch. And, your dose of pregabalin is minimal. I mean, I think you're on 425s right now, and we'll go down to 3.
Right.
So 75 milligrams, and the maximum for that drug is 600 milligrams. So I think, we're in the bottom rung. And for the toothache or nose receptive like pain, you're on a gram in the morning and a gram at night of acetaminophen, and that really, for anybody over 65, is the preferred thing. So I don't mind you reducing, but I think that we're in a good zone.
Well, you got me there. That's for the record. So yeah, we're doing very well in terms of pain management.
I think it's great. Okay. And listen, if you were giving somebody else advice if they were asked to get their toes taken off, what would you tell them?
Toes taken up?
Taken off.
Taken off. I would tell them to immediately seek out help from the medical profession and zone in on the Etobicoke area if they are looking for any assistance. But seek help immediately. There are options available that really aren't well known out there in the market.
Mm-hmm. Okay. Well said.
Thank you.
Anything that you would say?
No, it's just a miracle. Taking a look at his toes, especially today, and looking back at those pictures, it really truly is a miracle. Thanks to this office.
Okay, thank you.
Okay, next slide. I think the take-home messages are linking edema to the history and physical findings to ensure appropriate assessment of the cause. And you really do need to look at the whole patient. Check out Wound Prep 2021 and 2024 for a holistic and simplified approach. Recognize and manage the complications of edema. And you heard about infection. You heard that if you've got bilateral edema above the knees, think about a systemic cause. Patient education is necessary and ongoing. Involve other healthcare professionals when systemic causes are a consideration. Consider alternative management when appropriate, and correct suboptimal calf muscle activation with edema and lower extremity ulcers. And I think, Robyn, as we look at the various adjunctive therapies, I think the calf muscle activator does have a place in terms of the twitch response and in terms of increasing circulation and helping us with these modalities.
Yeah, no, that's absolutely true. And I would say patient education, you guys in the audience, everything you can do, say is very important, and say it over and over again, because if you've ever taken in a lot of medical information, sometimes it's too much. Studies indicate you need to tell them many different times. So good job. Thanks for listening, everybody. And I hope you enjoy the Jays game. We're here for questions if you have time.
Absolutely. And I just echoing what you're saying there, we are going to do a couple minutes of questions, so you're welcome to stay with us, everyone. But if you have to head out, I just want to remind everyone before you leave that we do have a number of webinars coming up in this same series, both throughout November and into early December, as well as January and beyond. So do check our website out at nswoc.ca. Even if you haven't had a chance to review the ones before, those are still available there as a recording too. With all that said, let's get into some fun questions here. We got quite a few. One is going back to the beginning of the webinar, maybe for Dr. Sibbald, but you're both welcome to, of course, jump in. Could you explain a little bit more about how pitting edema is classified for the +1, +2, and other grading? How does that represent in terms of depth and recovery time?
It's a very, very, if you like, inexact science. So 1+ is barely anything. A 2+ is maintained. A 3+, there's some depth, so a little bit of your nail is buried. And a 4+ is when maybe the majority of a fingernail might be buried. But, and whether you look at that in terms of a half, a 1.5 or 2 centimeters plus pitting, I think it's a relative measure. Just remember, though, that the amount of pitting you get over the pretibial area is often less than the amount of pitting you'll get just above the medial malleolus. And with misshapen legs, Robyn, there is some difference, but check above the knees. And if you've got bilateral edema above the knees, there's probably a systemic association. And, some patients have 2 or 3 causes for their edema, and you can't just stop at one.
And
Robyn, do you have anything to add to that?
No, I would just say, I think grading edema is very important for your own clinical notes so you know whether it's getting better or worse. So whichever method you use, just do it consistently. Sometimes even measuring it consistently can help.
If you're measuring consistently, do the mid-calf, do the just above the malleolus, and then 10 centimeters below the tibial plateau.
Yeah. But there's no exact science to this, unfortunately.
Talking more about more on the assessment side here, one person was asking about the clinical relevance of using the toe brachial index versus the ankle brachial index with patients with arterial calcification. I know it's very specific. This
Let
person is,
me go after this.
Oh, you
please
And
do.
can only
yes,
see the sounds.
yeah, and I think you need to listen to the 8 megahertz bedside Doppler sounds because it isn't influenced by calcification. It is true the toe brachial index may not be influenced as much by calcification, but you can do an audible handheld Doppler sitting in a chair. When you're looking at the measures, monophasic sound is shh, shh, shh. Biphasic is pshh, 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 pshh. Triphasic is pshh, pshh, pshh. Any multiphasic sound, and this is a study we did with Dr. Alavi on 200 consecutive patients through the Trillium Vascular Lab and published in 2015. And it was about 98% accurate with the vascular lab. And there aren't too many clinical tests. You can be sitting in a chair. It isn't influenced by calcification. You don't have to squeeze the calf muscle. You can record it on an MP3 recording on your cell phone and send it for verification. We can stop, and we have distributed 150 toolkits over Ontario with 8 megahertz Dopplers and infrared thermometers. And anybody that joins Project Echo in Ontario can be eligible for those toolkits. And there's about $1,200 worth of stuff in it. And when we get up and working with Indigenous Services Canada again, and David just put one of these Dopplers in my hand, and it's a handy tool to have, and it can avoid delays in compression therapy, and I think it is a game changer. Robyn?
Yes, I agree fully. But if you're looking at the ABI, the toe pressure would be more accurate than an ABI if you have
The
calcium.
toe brachial pressure.
Yes, so toe brachial pressure would be more accurate than the ABI, the arterial brake at the ankle, if that was the question as well, just to clarify.
Thank you for touching on that. We had quite a few questions that have come up about this sort of topic here. Can patients safely shower with open ankle wounds, such as some of the ones that we saw in the cases there? Some patients report avoiding showers for years even. They're scared of complications, of pain. What guidance or what advice would you maybe give to those patients who are, to those clinicians advising patients?
Robyn, go ahead.
So for those leg ulcers that I showed, I think it's fine to shower and dry them off. Patients cannot not shower for that length of time with leg ulcers. The big problem I find is if you have a diabetic foot ulcer and you're standing in showered water, that is a problem. But water running off your leg, I don't recommend you soak in a bath, but having a shower, drying it afterwards and putting the appropriate dressing would be reasonable.
And there are leg protectors. You can use saran wrap around your foot if you've got the diabetic foot ulcer. Shower, not bath, absolutely. And it's important to replace your dressing or to put an antiseptic on your foot post shower or bathing. And I think that's the important part to it. But yes, and I think people going for years without shower is really not very tolerable.
The cast covers that you can get on Amazon, and I'm not supporting Amazon in any way, but I did break my leg and I used one for quite a length of time, and it actually works terrifically well. It's cheap and it's very easy.
Thank you. Now, speaking about the wet surfaces here, someone was asking whether gecko can be applied to wet skin, or does it need to be dry to be placed on?
I would like it to be dry because you're using an adhesive and you want the adhesive. So I think it's quite easy to dry the skin. Jeff, do you want to comment?
Yeah, the adhesive is water soluble, so if you put it on a wet surface, it will actually just fall off.
Fair enough. Yeah. Thank you for clarifying that. And Jeff, since I got you on here, I know you've already answered in the chat, but did you want to just remind us what was the other muscle pump activator similar to gecko that was featured on Shark Tank?
Oh, that's
When we
the
talked at the very
Firefly
beginning.
device. So that's it's a lower power device that it's not effective medically, but it's effective from a muscle pump activation and in terms of muscle recovery. Elite athletes are a lot different than the patients that we're talking about today.
Good point.
Now, talking about, someone was asking about this. Is there a role for passive calf muscle pump exercises in non-ambulatory patients versus using gecko? Is a big discrepancy between having the gecko on versus doing muscle pump exercises yourself as a healthcare provider or caregiver?
Yeah,
You're no kidding. Go, Robyn, go.
I know for sure. Muscle, you should be teaching patients to exercise and how to dorsiflex and what kind of exercises you can do to increase. Even if a patient isn't walking, you can get that calf muscle pump working. And that should be part of what we do as clinicians for our patients.
One of the good aids is called TheraBends, which is like an elastic release that you hold and tense, and then you do flexion against a fixed resistance.
And I just see we're getting a bit of a discussion in the chat here, and I wonder if you want to comment on this. Sade was asking, what is the rationale for wearing compression stockings during the day but not at night? Some people are saying they think they can do compression 24/7. What's the thought behind that?
Where do you want to go?
Uh,
Go,
Is it
Robyn.
widely debated at the
Okay.
moment? Yeah.
Yeah.
So when you're walking and standing is the problem. There's pressure in the venous system, which we know is the cause. So we put compression on to put pressure on the veins and improve the valve function. So that's very important when you are standing. When you're lying down at night, there's no pressure in the venous system, so it's not as important to wear it. However, when we would put on compression wraps, they do leave them on all night. So it's not a problem, it's just not required. And I think most patients need to take off those compression garments at night, moisturize their legs, and in the morning put them on before they walk around and the edema forms again. So putting them on first thing in the morning.
Yeah, I'd agree with that. If anybody has a level of ischemia and you have your legs up and gravity is not helping you with your arterial circulation, then you can get a much lower arterial circulation, especially to the feet and, the toes. So I don't think it's something you should think about. One of the ways around that, and some elderly people have trouble taking them off and on at night, and you can push them down around the ankle, but something like Edema wear has a vertical mechanism, and it works by fuzzy whales, localized capillary action, and they're probably much safer to wear at night. Robyn, do you want to comment?
No, I think that's perfectly reasonable. But I think
Yeah, and the other thing is that people will come in and say, "Oh, I can't wear my compression; it's cutting off my circulation." And I'll roll down my socks and say, "Look, those are the only good wrinkles in life. The wrinkles under compression means it's working."
Yeah, good point. That's always very satisfying to see.
And I have a couple questions here about gecko again specifically. One is asking, is this different from the standard transcutaneous electrical nerve stimulation or TENS machine in terms of mechanism or its effect? Or is it about the
Jeff,
same?
why don't you answer that? But yes, it's very different.
Very different.
Yeah, a TENS system is designed for pain management. It targets the sensory nerves. This targets the motor nerves. It's not even remotely the same.
Gotcha. And then on that note, someone else was asking, does the geko device only provide benefits while it's in use, or do you see lasting improvements once the device is removed as well?
Actually, Dr. Sibbald, maybe,
Yeah, I
Jeff,
can answer that.
you can both
And I
comment on the
think,
data.
yeah, and the random controlled trial from Keith Harding and group really showed for 4 weeks compression, those ulcers not healing at the expected rate were randomized to compression alone or compression plus geko. They doubled the healing rate at week 8, and that doubling healing rate continued at week 12 and 16. So that once that was reestablished, and you know, there must be something in the geko. And as we look at arterial disease now and the geko, it seems like it's working like exercise and it's opening up new pumping mechanisms. So you may exercise in bed and do the flexion for 5 minutes every hour. But you got to remember a geko device is on for 12 hours continuously. And so that it really has, and we have seen some patients with improved arterial circulation. This is anecdotal. It needs more study and prospective random controlled studies, but looking at the mechanism, looking at the studies with the edema control post-pancreas and pancreas kidney transplants, I think we can see that there is a utility to the geko device and what it does in terms of motor function. Jeff, do you want to add to that?
Actually, no, I think the what you're describing is what we're anticipating, is that you know, when you start pumping blood, a lot of other things happen. You get capillary beds open. You're probably you know, there's a case that I know you dealt with where you started seeing pulsation where pulsation didn't exist, and so I think it's nature working, right? It's the calf muscle pump starting to work, and where it wasn't before. So I think that's really what's going on.
And also, once you start getting rid of that edema, patients can walk a lot easier, put on their shoes. It's,
Yeah,
you
good
know,
point.
less pain. All of these things become variables in terms of trying to get rid of long-term edema. So that's a really good question. Thank you.
I'll get to maybe hoping we can do a couple pathophysiological questions, and then I know we're getting towards the end of our time here, but let's do this here. Someone was asking.
Sorry, a ton of
Yeah.
questions are coming in the chat as opposed to
Okay.
Q&A, which I know we have limited time, but at any rate, there's a lot there.
Absolutely. I know some of it is talking still about the compression conversation and overnight compression and things there too. But maybe one of the ones that came in through the chat and has been asked quite a bit, we'll keep you on here, Jeff, for a second, is the availability of geko to long-term care homes and the cost or cost savings that geko offers.
Yeah, long-term care is actually the biggest user of geko right now, so it's widely available. And there's a new study to be published soon that will show, for those of you that attended Wounds Canada, you saw a presentation on cost effectiveness. There's about $1,000 savings per patient, and that will be published hopefully soon.
And can geko be used for patients with DVT?
Well, actually, it's intended. The original intent of geko was for prevention of DVT on long haul flights. So the answer is yes. However, with a patient with an active DVT, we recommend caution because you don't want to mobilize a clot and end up in a pulmonary embolism.
Yeah, so it should be treated. It has to be treated first, of course.
Yeah.
Perfect. So a couple questions to finish us off here, Dr. Evans and Dr. Sibbald. One is from a pathophysiological standpoint, what causes that champagne bottle appearance of the lower legs in chronic venous disease? I know you were showing one of those examples earlier, Dr. Evans, too, where you could see that shape, or maybe it was Dr. Sibbald, we could see that shape very clearly.
Robyn?
So, all that woody fibrosis actually causes the skin to get very, very tight and lose some of that sort of fatty tissue, and it's changed to this fibrotic tissue. And most of it's in the lower part of the leg, whereas the upper part is not as affected. And so you get that champagne bottle deformity, which is sort of end stage venous disease.
The upper leg has more fat, and so that you can lose very little fat in the lower part, and it becomes very restrictive.
Yeah, it's not very comfortable for patients.
And for patients with pain, what causes pain in patients with venous disease who experience discomfort or pain first thing in the morning when they hang their feet over the side of the bed? What
That's
could
the
potentially cause that?
that's the fluid filling up the veins and the leakiness of the capillaries. And, you know, in venous disease with valvular disease, which is the most common, you not only get leakage of fluid, you get leakage of red blood cell. And the red blood cell breaks down and it leaves behind hemosiderin, and macrophages leave behind melanin. And it's the hemosiderin and melanin that, you know, you'll see the pigment and the woody fibrosis as the disease progresses, and it is extremely painful. It used to be in the old textbooks that venous disease was not painful. Well, it's very painful, and it can be first thing in the morning. And one of the things is that it's both nociceptive, it's toothache-like pain, but it's also the burning, stinging, shooting, stabbing. And people with venous disease have an average age of 70, and they may have B12 deficiencies, vitamin D3 deficiencies. They may have undiagnosed diabetes. They may have high iron or thyroid disease. So there's lots of things coexisting along with the edema causes that Robyn mentioned of the liver, the kidney, and the heart.
Thank you so much for touching on that. I think we're getting towards our time here. I saw Trish from our chat. Trish is one of our past regional directors for ISTAP for Africa. And she was asking whether geko will be represented at Wounds UK next month. So Jeff says yes here. And I want to remind everybody that we have our own joint congress coming up at the end of April 24th to 28th in Vancouver. That will be another great opportunity for those in Canada who are expecting to come to our NSWOCC and WCET joint congress. So lots of great opportunities, but I wanted to shout out Trish there, who's tuned in from South Africa. Thanks for joining us today. So we've gone fully global today at this webinar. Dr. Evans and Dr. Sibbald, I want to thank you so much again. There's been so many phenomenal or so many great messages in the chat here. They love it. Everyone's saying this is so great. Lots they can bring back to their wound clinics. So this won't be the last time we'll see you both. I'll remind everyone in the chat that we will have some more webinars coming up as soon as our next one will be on, up for here. November 24th will be our next webinar in this series. We have other webinars, of course, too, but unraveling compression will be the next topic on November 24th, and lots of great things to come in the future, too. So just a reminder that we have recorded today's session. You can watch today's back or any of the others in the series that you haven't had a chance to see yet. You will be receiving a certificate of attendance, and we're going to be sending you a survey as well in that email. So do take a chance or take a second to respond to that survey, and it'll really help us for developing some great educational series for you in the future. So with that, we'll say go Jays go. Thank you again to Dr. Evans and Dr. Sibbald.
Thanks very much. Thank you, geko.
Thank you.